Thank you very much and welcome, Adolf.
It's a high privilege, of course, to join you today. And thank you very much, Wilson and Madam President, for this privilege to welcome our distinguished speaker today. My name is Adolf Nevishaka, Education and Development Department Committee member. Ladies and gentlemen, esteemed members of the operating room global audience, it is with a great pleasure that we introduce Professor Dr. John Imaralu, a distinguished medical professional and an expert in the field of obstetrics and gynecology. Professor Imaralu holds an impressive array of qualifications, including Bachelor in Medicine and Bachelor in Surgery from Nigeria, Fellow in West African College of Surgeons, and Fellow in Medical College of Obstetrics and Gynecologics from Nigeria, Master of Public Health, and the Fellow in and a fellow from different fellowship programs from India with a medical doctor from Nigeria. Currently serving as a professor at Babcock University and an honorary consultant obstetrician and gynecologist at the Babcock University Teaching Hospital in Ilsan-Lemo, Ogun State, and in Nigeria. Professor Imaralu has played a pivotal role in advancing the field of gynecological surgery. As the pioneer head of the department, has actively contributed to the development of frameworks, regulations, and guidelines for professional and academic training of resident doctors and medical students. Thanks to his efforts, the institution has successfully obtained full accreditation status from relevant regulatory bodies. Professor Imaralu's expertise extends to leadership, mentorship, and academic and clinical training, particularly in surgical preceptorship access surgery, where his trainees consistently excel in postgraduate examinations. Notably, he was instrumental in establishing the endoscopic surgical unit at the Babcock University Teaching Hospital in 2016, where advanced operative and diagnostic procedures are now conducted regularly. As a team lead for the endoscopic surgical unit, Professor Imaralu coordinates the activities of various departments involved, demonstrating his commitment to the advancement of surgical practices. He is also an examiner at the West African College of Surgeons and an active member of professional organizations such as AGES, AFLH, SOGON, ASLM, among others. A prolific scholar, Professor Imaralu has authored over 50 scholarly publications in peer-reviewed journals and books, many of which focus on gynecologic surgery. His dedication to academic excellence is further highlighted by his role as a journal editor and a reviewer for several high-impact journals. Beyond his professional accomplishments, Professor Imaralu values family life and has a passion for playing table tennis. With such a comprehensive background and wealth of experience, we are deeply honored to have Professor Dr. John Imaralu as our esteemed speaker for today's webinar on emerging trends in gynecological surgery, what's on the horizon. Ladies and gentlemen, please join us in welcoming Professor Imaralu to share his invaluable insights with us. You are highly welcome, Professor.
Thank you very much. I feel honored to be amongst you and to be presenting today. Thank you very much.
You are welcome.
So I await the cue to go ahead. If you give me the permission to go ahead, or I don't know if there's any further thing. So I'm
Yes, sir.
waiting.
You can
I
go
wait your
ahead.
cue
No
to go
problem.
ahead.
No problem.
All right.
You can start. Yeah.
Okay. All right. Thank you very much. Like I said earlier, it is an honor to be presenting this topic. And apart from that, I always feel excited for every opportunity given me to share knowledge, especially knowledge that will improve practice in the care of women and improve the lot of women folk. I always tell my colleagues and my friends that, you know, if man was one of God's best creations, the woman is the later version. You know, we also compare it to cars. If you're buying a car, the woman is the later and the better version if you want to make a better version. So with this in mind, I'll be presenting this topic, emerging trends in gynecological surgery. What's on the horizon? I would like to know also if I'm off air. So maybe occasionally I would like other people in the admin to just interject so that I'll know that I'm not talking to myself. I hope you can hear.
Yeah,
So
we can hear you.
occasionally I want to know. All right, thank you very much. So I'll be using this outline. I'll introduce with historical trends in gynecological surgery. I'll mention the drivers of change in gynecological surgery, how the practice has, been responding to these demands, the impact of the emerging trends, the future of gynecological surgery, then AI in gynecological surgery, and I'll conclude thereafter. Now, gynecological surgery has been a pioneer in surgical innovations. A lot of the innovations in surgery have come from the gynecological field. Gynecological surgery has witnessed a rapid progression in contemporary times. A high proportion of innovations in surgical care has been contributed by gains in gynecological surgery. Now, just the historical trends. I'll be mentioning that in the basic sciences, in equipment and instrumentation, and in the technique, surgical technique itself. Now, the first description of the human uterus was by Soranos, and the first accurate description of the human oviduct was fallopian tube, and was by Gabriel Fallopio, after whom it was named. Then the vulvovaginal glands or Bartholin's glands was first described in 1677. And the finest work on uterine anatomy up to date was by William Hunter in 1774. In fact, since that time, there has not been much new discoveries relating to the uterine anatomy. In fact, the pictorial description was an artistic success at that time. Now, talking about these trends in the devices. In 1805, Philip Bozzini introduced his light conductor, which you can describe as the earliest version of the endoscope. In 1825, Mary Ann Boivin described the bivalve speculum. Today, a modified version of that, the Cusco speculum, is readily used everywhere today. In 1878, Graves, T.W. Graves, made a modification of the bivalve speculum, combining the Sims type and the one devised by Biovin. Alfred Egger introduced the medical dilator for the cervix in place of laminaria in 1879. And in 1893, Howard Atwood Kelly devised what he called the air cystoscope for inspection of the bladder and identification and characterization of ureters. In fact, 5 years after that, the first attempt at radical hysterectomy successful attempt at radical hysterectomy was made without injury to the ureters. Raoul Palmer in 1941 popularized the use of laparoscope in gynecology. Now talking about the surgical techniques, the first report of ovariotomy was performed by Ephraim McDowell in 1809. In 1813, which happened to be the year of birth of Marion Sims, which many consider as the father of modern gynecology, you know, Conrad Johann Martin Lagenbeck first performed the first successfully planned vaginal hysterectomy. The first surgical correction of vesical vaginal fistula in the United States using less sutures was by Peter Matter in 1838. Myron Sims described his own method of VVF repair in 1852. And in 1898, like I said earlier, the first radical hysterectomy for cervical cancer was performed by Ernst Wattem. Today, we call that procedure Wattem's hysterectomy. In 1900, Fanensil described a transverse incision for laparotomy in gynecology, which is gaining wide popularity now against the vertical incision for laparotomy. Wilhelm Lasker described his own technique for the closure of the vagina after hysterectomy. That's vaginal closure after hysterectomy. That's anterior corporaphy. Ralph Hayward Pomeroy described the Pomeroy's method of tubal ligation in 1929. Now, in 1845, the first abdominal mammectomy was performed by Washington Atlee. The first report of abdominal mammectomy was by Washington Atlee. In 1898, Adam Alexander presented 11 cases of abdominal mammectomy to the British Gynecological Society of London. This resulted, he was put down because they felt it was too daring, because at that time there was a belief that mammectomy was a bloody surgery and could be life-threatening and patients would die. So despite his hope that it would be accepted, he was put down and he was castigated, and because of two reasons. Mammectomy was too dangerous and the blood loss made it too dangerous. So everybody reverted back to hysterectomy as the operation for fibroids. Something happened 10 years after. Somebody called Annie B. I want to use B as her surname. In 1907, 2 years after marriage, she developed menorrhagia. And this is what Victor Bonney said about her. In my years as a gynecological surgeon, a case occurred which profoundly affected my outlook. A lady, recently married, wishing above all things to have a child, underwent a subtotal hysterectomy on account of a single submucous fibroid. Being a woman of strong character and resident fortitude, she accepted the blow without complaint, and by assuming a proud indifference to children, held her insistent mother instinct at bay, and none but those who knew her well perceived the tragedy. I was among this number, and the grief of it still came in me. That was Victor Bonney in the early 1900s. Victor Bonney happened to be the pioneer of the conservation era, preservation of organ era, and and in fact, mammectomy as treatment for uterine fibroids. Incidentally, that woman, Annie B, was actually Annie Bonney, his wife. That event actually transformed his world and his practice forever. Already well known for radical surgery for carcinoma of the cervix, radical hysterectomy, he switched and started looking for ways to treat fibroids. This woman had to undergo hysterectomy 2 years after marriage, so she had to be sterilized, just like that at that era. So he invented, he started performing conservative surgery, started with the ovaries. He invented the bonus mammectomy clamp, which we all know about, which helped to limit blood loss. He invented that in 1946. He also used rubber tourniquet on the infundopelvic ligaments to cut off blood supply from the ovarian artery and limit blood loss. This man also devised a mixture of crystal violet and malachite grain in alcohol as antiseptic for skin preparation before mammectomy to reduce infection. He introduced dead space closure after myoma enucleation, and also introduced the bonus hood incision, especially to prevent posterior incisions for removal of posteriorly located uterine fibroids. This man, in his entire surgical life, performed 700 mammectomies. 38% of his patients achieved conception. Thereafter, 4% had fibroid recurrence, and 8 out of the over 700 died. That's bringing it to 1.1%, as against the belief at that time that every woman who had mammectomy is risking their life for uterine fibroids. Now, you agree with me that necessity is the mother of invention, and this can be credited to Plato, one of the world's greatest philosophers. What are the drivers of change in gynecological surgery? One is the need to improve safety, as against what the Royal College of Surgeons taught in the late, 1800s, where they thought, mammectomy would be, for fibroids will, increase death. This led to a lot of innovation, and Bonny, devised a lot of things to improve safety of the procedure, conserve blood, is body mammectomy clamp, limitation of operative mobility, preservation of fertility function, and preservation of function of organs, especially ovaries, breasts, despite treatment. Other reasons include those to my right. Imagine trends in patient demands. Today, a lot of our female patients, for their career reasons, for occupational reasons, want certain kinds of surgery or certain surgery done in certain ways. They want to preserve the ability to procreate later in life. And many of them desire plastic reconstruction today, breast, vaginal surgeries, and minimally invasive surgeries. And also they want to preserve their sexual function, to preserve their sexual self-esteem. How do practitioners perceive these demands? The healthcare practitioners, how do we see it? Ethically, we look at two principles of ethics here: respect for persons and the ability to reserve, for the patient to reserve their ability to make choice, which is autonomy. And one question we keep asking is, can the wholeness and bodily integrity of our patients be preserved and the disease condition still optimally managed? Is it possible? How are we responding? How is the practice of gynecologic surgery responding to these demands? Now, minimal trauma, innovation, and multi-modality. These three form the principles of modern gynecologic surgery today. What are the benefits of the changes that have occurred in gynecologic surgery? These include patients now have more choices to make. They now have more options. More women can retain their female body image. No laparotomy, or I would rather say less laparotomy and less major surgery. Reduced duration of hospital stay. Less sick time and less sick leave, and fewer long-term complications. Pain is also less. Blood loss is also less. Faster post-operative recovery, and less perioperative and post-operative adverse events, reducing costs. However, it has sparked off the trends, the newer trends now, has sparked off a lot of debates. But these debates are positive because they have raised, a lot of research questions, and research is ongoing in gynecology. It's a very, very busy field. The impact of emerging trends, all fields are affected. Surgeon, anesthesiology, perioperative, technical staff are affected. The route of surgery is also affected. The surgical techniques are affected. The complexity in instruments becoming, instruments that can perform a lot of things. The operating time has undergone a revolution. Changes in pain management, specialization and subspecialization, then increasing collaborations resulting in interdisciplinary management of patients. In a nutshell, patients are actually getting the best or getting better than the women folk are getting better. Their lot is better now than before. Now, what we see here, minimal access and minimal trauma, organ preservation and reconstruction are what we have today in gynecological surgery. Innovation, this talks about, better endoscopic instruments, more endoscopic surgery, improvement in endoscopic technology, better optical electronic system, improved intra-abdominal recovery systems, tissue retrieval systems, musculators, shavers, intrauterine shavers, and so on. Better distension media, advances in distension media, both for laparoscopy and hysteroscopy. Innovation is the key. Today we have multimodality. There's an interplay between different treatment modalities. radiation, chemotherapy, surgery. Good use of investigative modality, MRI, for instance, MRI for laparoscopy or hysteroscopic mammectomy, for instance. Then laparoscopy before cytoreductive cancer surgery, or second look laparoscopy for nodal assessment in gynecological cancer. Several modes of treatment are considered for particular disease condition, and we have interplay of different specialty taking care of individual patients. I'm now going to talk about specific areas. Fibroid surgery has undergone a lot of revolution, and most of fibroid surgery are now done laparoscopically, hysteroscopically, and we have increasing use of robotic assisted mammectomy rising every day. Now, uterine conservation now is the key. Research into fibroid surgery also rapidly ongoing. What about the cancers of the female reproductive organs? The breast. Today, there's an increasing trend towards breast conservation and use of implants. And laparotomy for uterine cancers used to be the norm in the past, but today, most of cancers can be treated via minimal access and screening via vaginal natural orifices transluminal endoscopic surgery. And laparotomy used to be in the norm before. Now we have laparoscopy. And even in the treatment of early stage, where we have cervical cold knife colonization in the past, that has become largely obsolete. Today we're able to do loop electrical excision, large loop excision of transmission zone, and cryotherapy are much more popular today. Hysterectomy, before, abdominal hysterectomy used to be much more commoner. Today we have hysterectomy by minimally invasive techniques. Hysterectomy was once the treatment for fibroid. Today hysterectomy has decreased as treatment for fibroid, especially for women in reproductive age. Yeah. Ovarian conservation now is common in patients having hysterectomy today. Now, incontinence and prolapse surgery, gynecology has also witnessed a lot of change also. Many of the procedures done vaginally can actually be done today with local anesthesia. Location. In the past, patients spent several days in the hospital being monitored with beta ECG, ultrasound scanning, and so on. But today, we can easily resolve the issue and patient can go back and continue our life. We don't have to keep the patient in the hospital. Laparoscopy has revolutionized that. Surgery for ectopic pregnancy before used to be the norm. Today, most of the cases are laparoscopically done, except a few cases where laparotomy is indication, where we have grade 3 shock and the rest, especially from hemoperitoneum. Now, treatment of unruptured ectopic pregnancy used to be conservative. Tubal surgery used to be done by laparotomy in the past, but today, laparoscopic conservation is the norm in today's world. Sacrilege also has been revolutionized. Today, laparoscopic transabdominal sacrilege is it's gained a lot of popularity. What about anesthesia for gynecological surgeries? General anesthesia, has come to stay, has undergone also transformations on its own. We won't say it has reduced because minimal invasive surgery also uses general anesthesia. Combined spinal anesthesia is increasing use, and regional anesthesia or local blocks are becoming popular because of the higher resolution to vaginal surgeries. Generally, incision has also witnessed some changes. Transverse incisions are now much more popular than midline incision, and for abdominal myomectomy, when it is indicated, or hysterectomy, mini laparotomy and ultra mini laparotomy are now possible. Wound closure too. Today we have innovations, staples, advances in surgery, intracorporeal, extracorporeal suturing and knotting, and use of fibrin glue have become very popular. Minimally access surgery has also undergone a lot of revolution. Minimal access surgery, you'll notice from my earlier tables, has started many years ago in the 17th century, long ago. In the early days, we have this, you can see a picture of Christian Jacobius there. It's trying to look in peritoneal cavity. So this is just a chart to show changes in laparoscopy. Earlier in laparoscopy, we have what we call the era of diagnostic laparoscopy. Today, we're in the era of operative laparoscopy. You can see the trends. George Kelly in 1901 did his experiments on dogs. Christian Jacobius worked on humans, and then Scott worked on humans. You can see insufflation in 1924 became popular, and they started peritoneum with gas, right? In 1938, Janos Verres invented the Verres needle for creating pneumoperitoneum. In 1963 by Kotzem resulted in the development of the insufflator machine. Kotzem also was the first to perform laparoscopic appendicectomy in the early 1980s. The first laparoscopic hysterectomy was performed in 1989 by Reich and so Henrik Newey performed the first laparoscopic cholecystectomy in 1985. Now, so the advances have been virtually all aspects of the optics and viewing system, from the eyepiece to teaching. Now we have smart monitors today, from single chip cameras. We now have 3-chip high definition cameras, and we have cameras with archiving systems. Entry has also been revolutionized. The session technique, we now have bipolar devices that can cut and seal at the same time. Retrieval system has also been undergoing their own revolution too. We had the morcellation era, the anti-morcellation era. Now morcellators are returning back now. So the instrument today, we have robotic surgery, robot-assisted laparoscopic surgery now becoming in vogue. These are just pictures showing reservoir systems. And what is the future of gynecologic surgery? What is the future of gynecologic surgery? Single incision laparoscopic surgery, robot-assisted single incision laparoscopic surgery is coming up. Then gasless laparoscopy, we may soon witness an era of gasless laparoscopy, especially for patients in whom pneumoperitoneum is contraindicated, such as patients with obstructive pulmonary airway diseases, heart conditions, and so on. Robot-assisted laparoscopic myomectomy is gaining ground, and robot-assisted transabdominal sac also. Enhanced recovery after surgery is another principle, another concept that may come to stay. It has been shown in meta-analysis to be associated with decreased hospital stay, decreased complication rates, decreased readmission, and savings in terms of cost. Is an evidence-based care, which I'll look at later. You can see it here. Do you know that today patients can take fluids up to 2 hours before surgery, because the kind of surgeries we are doing today are now minimally invasive? Patient can also have carbohydrate loading, can have carbohydrate drink up to 2 hours, because that has been shown to reduce, insulin resistance and enhance post-operative recovery and return to oral regimen, and single-day discharge or early discharge from the hospital. Pre-operative medications have also, patients can also have their medications. High evidence level have been shown for the use of NSAIDs before for analgesia. Intraoperative analgesia, continuous wound infiltration via local anesthesia, and in the abdomen has been shown to be better than epidural anesthesia. Well, strong recommendation there. Catheters can be removed as soon as possible after minimal invasive surgery and within a day of laparotomy. Venous thromboembolism prophylaxis, post-operative opioids, using multimodal analgesia was also recommended. Now, the future of gynecologic surgery also will be largely influenced by artificial intelligence in gynae surgery. Here we talk about physical and virtual AI. Physical AI helps much more in surgical field. Virtual AI uses established, patient factors, treatment algorithms to predict outcome. Whereas physical AI, especially 3D, 3D printing, has been shown to aid in robotic surgery, help 3-dimensional, better than the 2-dimensional of MRI, can plan robotic surgery and know exact depth and extent and extent of involvement of adjacent structures, especially when a surgery is being planned, especially those operating cancers. There's an invention not included here, a device that can be worn by surgeons that can help identify cancer cells, immunofluorescent device that can wear that can help to identify cancer cells during surgical operations. You know, this is a saying by Machiavelli: there is nothing so difficult or dangerous as to change the order of things. What do the gynecological surgery team members, what should they expect? Hello? Okay. Can you hear me?
Yes, we
Yes.
can.
Yes, sir. Yes, sir.
Surgeons.
Yes.
Okay.
We can hear you.
Okay, great. So there is increasing demand. These advances put a lot of demands on surgeons for subspecialization and even super specialization. And many of the procedures require special training. And the modules that are used are mainly, simulation-based modules. You cannot go and train on the patient. In fact, before you do a procedure, you're expected to simulate the procedure on an endo trainer. So there are simulation-based modules both for the surgeons and the surgeon assistant, the perioperative nurses. In fact, also, the anesthesiologists may have to simulate what they're going to do in certain types of surgeries before they go. Now, the increasing also is the use of technicians. We know that anesthetic technicians are there. Now many of the hospitals are now employing technicians on the surgical side, surgical theater technicians who will be the interface between the surgeon and the instrument, because more complex instruments are being developed. The care of the instruments, also needs some special training as well. The management, hospital administration, hospital management also needs to be abreast of changes that are coming in, so that patients will be given the best. Hospitals will be put in line, because there are rapid changes occurring every time. This is just my own view of what the future of gynecological surgery is. This picture was taken in 2015 in Delhi, in India. And in conclusion, gynecologic surgery has witnessed tremendous evolution in recent times and a shift in paradigm from extensive anatomical exposure and extensive intraperitoneal search, to minimal invasiveness and conservation of natural, aesthetic, reproductive, and occupational capability, despite optimal care for varying severity of disease conditions. I want to thank you for inviting me and for your attention. So I'll pause for questions and comments. Thank you very much.
Thank you so much, sir. I really enjoyed the topic. You really dealt with the topic, and I'm sure that each and every one of us that attended this webinar knows that you did justice to it. Thank you so much, sir.
Thank you very much.
Yeah. So, just as the platform, the audience, if there is anybody that have a question or clarification.
Okay, sorry, my name is Dr. Clement. I have a question. I don't know if you can hear me.
Go ahead, sir.
Yes, I can hear you. Go ahead.
Okay, yes, thank you so much, Prof, for this so wonderful presentation. I have interest in minimal affairs surgery, so it's so interesting. My question is, I saw that evolution going on around the world. I don't know. I here in Nigeria, there are so many challenges we are facing, and are there concerted efforts for more training? I mean, our teaching hospitals, for instance, I doubt they are ready for this sort of evolution. I don't know the readiness there, because some of them, sorry to say, we don't even have all the complete manpower training and specialization. And now we are even talking of surgical technicians. I don't know if there's any school in Nigeria that is already training surgical technicians. So I don't know. What's our level of preparedness? What are we doing to push it on, I don't know. That's something. Thank you, sir.
Thank you very much. I mean, should I take it one by one, or do you want me to take everything down and take
Yes, I just take it one by one, sir. You can go one by one, sir.
All right, thank you very much. All right, so thank you very much, Dr. Ekere. Now, your concerns are very, very valid and very, very important. Now, it's challenging, especially now that, virtually everything involving minimal access surgery is imported, including the training. It's just recently that we have started having some centers in the country that are accredited for training minimal access surgery, both for the physicians, for the nurses, and recently for technicians. Now, we have one center in Abuja. We have another center in, somewhere in Anambra State where training is ongoing. And, the postgraduate training centers, the postgraduate training colleges have made it compulsory for all teaching hospitals where training occurs to have that training in minimal access incorporated in their training curricula. So that is ongoing. So there's training is available. Then we have an association that has been pioneering gynecologic endoscopic surgery in Nigeria. We call it AG, Association of Gynecologic Endoscopic Surgeons of Nigeria. They too also offer training. They offer fertility-based training for different institutions. In fact, I'm a member, and presently we're in the process of approaching all the teaching hospitals and from secondary to tertiary level hospitals, so that we can come in and train their staff, because that's where the world is going now. In fact, in the developed world, most surgeries are now done minimally invasively. Only fewer surgeries are done by laparotomy today. So the AGs offers training to all these institutions. Because we are in the process of, having MOUs and proposals with them to invite us to come and do training for their, for their staff. In fact, all the funds should have some basic training in minimal accessory, and those that want to subspecialize can go ahead and subspecialize. So I think that is it. Now, the other challenge we have are equipment and instruments, and here we'll need some advocacy with the, with the policymakers, the, governments and so on, governments of states and governments at federal level also, to encourage this, so that, we have to put ourselves in the global recent trends, global recent best practices regarding surgery, generally, whether gynecological or other forms of surgery. So we need some advocacy. We need to inform them. We need to inform the policymakers so that they can, put our country and, many other sub-Saharan African countries at par with what happened, global best practices. I think that's what I hope I've been able to throw some light on your question. Thank you very much.
Thank you so much, sir. Thank you so much, sir.
Welcome.
Concerning the training, sir, presently in Nigeria, we have a SNEMIT, that is Society for Nurses in Endoscopy and Minimal Invasive Surgery. So they are majorly training people in minimally invasive surgeries and endoscopy training. And they have done some conferences in Lagos, Port Harcourt, and some parts in the north. So majorly there's some school of therapeutic schools that they collaborate with them. Presently, UCH Ibadan is one of them. So since 2018, they have been training most of their students in endoscopy and minimally invasive surgeries. But other people that normally comes to UCH for their practice normally join during the training, like IRUA, some of them join during that training. But the advocacy is not that, let me say, serious per se, because some establishments don't really see why they need to invest in minimally invasive surgeries. As you are rightly said, most of all these consumables are coming from outside the country, and if there is no reduction in price and other things, most of those things we find it difficult for anybody to purchase. So, which I think is part of the major problem in which some people are not venturing into it. Thank you so much, sir. So, do we have? Okay,
Thank you
there
very
is a question. Yeah, the person is asking that with the increased technology, do you think that centers of excellence needs to happen? So, I don't really understand the question. I think
Yeah,
if the person
I
can,
do agree. I think no, if I get what he's trying to say, I do agree with him. I agree with him. Hello? Hello?
yes, I'm with you, sir.
Can you hear me now? I agree with
Yes, I
him
can hear
totally. Yes, we should have centers of excellence in minimally invasive surgery scattered around if possible, the 6 geopolitical zones in the country. That way, we'll be able to. That will also enhance training. People will know where to go within their reach, within their region where they can have training. It's very important, very very important. And like I said, to start up equipment and instruments, that is where the challenge is. Logistics, that is where the challenge is. And it's difficult for individual institutions to just go into it. They need funding from the government at state level and federal level to power these things. And I think that's where advocacy comes in. The centers of excellence are required. They will boost the whole thing in a very big way. Yes. Thank you very much for the comment.
Oh, okay, thank you, sir. Personally in Lagos, there are some hospitals that they do more minimally invasive surgeries. So, like Care Hospital, they are the pioneers of minimally invasive surgery, both neuro, gynae, urology, any specialty at all. So, so that is one. I don't know any other hospital that have um, that capacity to
Back up. Yeah.
do that.
So, somebody
Okay,
is
someone
raising her
said,
hand.
yeah,
Somebody
can you talk
raising their
more?
hand.
Miss Olafemi, are you there?
Hello,
You can
Hello,
can
unmute
ma'am.
you
yourself. Yes.
Can
hear
talk,
me
ma'am.
now? Can you
Yes, we
hear
can
me?
hear you. We
Okay,
can hear you.
okay. I want to appreciate Professor Imaralu for that, for the presentation. I have some questions for him. The first question is that you said that minimally invasive, as you all know, that is more cheaper for a patient. But in a situation where a patient is booked for minimally invasive and the procedure failed, are we going to charge the patient for open surgery? That's the first question.
Okay.
Hello? Hello?
Yeah,
We
we
are
can
hearing
hear
you,
you.
ma'am.
Go ahead. We can hear you.
Okay.
Go ahead.
Okay.
Go ahead.
Then the other question is that we're talking about minimally invasive training in usage. We, like me, have been to that usage, but the weeks that we used to for the seminar, it was just too short, 2 weeks. So I've been asking Professor. I am a nurse from Babcock. I've been asking Professor Imaralu, where can we go for the training? For those that are really interested in MIS procedure, where can we go for that training so that we'll be a master, not just we want to be a master on that. Then the third question is that she said that the gynecologists, they have a device for detecting cancer. Please, can you go over that devices again? Thank you.
All right, so I'll take the first question and the third and part of the second one. Now, the first one talks about, payments for laparotomy. If a patient doesn't complete the surgery via, is it laparoscopy or hysteroscopy now? Now, every patient that is coming in, I just want to let you know what we do. Every patient that is coming in, you counsel and let them know that there's a risk of conversion. In every minimally invasive surgery, whether gynae or not gynae, that risk of conversion is there. Now, when you are doing that, I would advise you factor that into your bill. When patient is coming, minimally invasive surgery, in terms of payment, when we're talking about being cheaper, it's not in terms of payment for the procedure. Is in terms of the overall cost. Reduce hospital stay, reduce post-operative morbidity, reduce pain, reduce analgesia, reduce infection, reduce all those are the overall costs. So it's cheaper in that aspect when you consider all of those things, not the payment for the surgery now. Now, when patients come in, your payment for the surgery should factor in that possibility of conversion. The surgeon gets there and finds out, or they convert for any reason, whatever reason for which they convert. I don't think the patient should be billed again, because that should have been factored in from the outset.
Okay.
The only added cost to the patient, maybe because of laparotomy now, patient may stay longer in the hospital. That one is different. But for the procedure, in terms of procedure, I don't think so. Now, the second aspect, I will answer partly, and I'll allow Olafemi to also add to it. That second aspect, there are training centers now. He just mentioned that there's a training center, there's the Association of, minimally, Nursing Association of Minimally Invasive Surgery. They collaborate with the University College of Ibadan to organize conferences and training. So I think you can get in touch with them for that. But we also have recognized training centers in Nigeria. One is in Oka. Life Training Center is in Oka. Then there's another one in Abuja, Garki, that also trains, both of them train at all levels. They train the doctors, they train the perioperative nurse, and they also train technicians. We also have Association of Gynecological Endoscopic Surgeons in Nigeria. We also train at all levels too. We not only train the doctors, the PON, and the technician. We also enlighten the administrative staff too. We bring them whenever we visit an institution. We bring in the administrative staff. We make them know what we are doing. A form of advocacy. That's AGs. Now the third one. Recent research study has shown a device like a Google, a device that can be worn by a surgeon. It's a recent thing by in research findings in the United States. The surgeon is not limited to gynecology now. The surgeon wears it, and that thing can actually, because of the changes in wavelength and reflection from the tumor cells, the surgeon can actually see, some things, differentiate normal tissue, normal healthy tissue from cancerous tissue. That can help him know the extent of his debulking surgery. So that's actually what I meant. So I'll just pause for last comment to throw more light on the training aspect. Thank you very much.
So thank you, sir. So for the training, the major issue is not because even if you undergo a training and there is nobody that is doing it in your center, on the long run, you will be forgetting some of those skills that you really acquired during that training. So for training, we have a Society for Nurses in Endoscopy and Minimally Invasive Surgery, which the Nursing and Midwifery Council of Nigeria has approved that it can be 3 nurses for endoscopy and minimally invasive surgeries. So, and I know that most people join because the resident is in UCH. So the partnership with Perioperative Nursing School in UCH. So every member of the set from 2018 till date, they are
Okay. Hello. Hello.
hello, are you with me now?
Hello. I can hear
Yes,
you now.
Hi.
we can hear you now. You went up briefly, but we can hear you now.
Okay. So it is a training. So if anybody wants to collaborate, maybe your establishment wants the SNEMIs to come and train in your establishment, they just need to uh, maybe I've got contact with me, so I'll be able to liaise with the managing team so that there will be a proper arrangement for the training. So, and they have done a lot of conferences in Ibadan, Lagos, and I think the one they did in Lagos was done inside the LUT because LUT also has a like a lab for minimally invasive training for I think for doctors, for nurses. So they have a mannequin like that. I think they set it up with the help of the customs. That was 2019, if I'm not mistaken. So we have some centers like that, but the major thing is that when you acquire the skill, you must, even if they are not doing it in your establishment, you must get somewhere where they are doing it so that you can be going there to at least to exercise your skills so that by the time you are able to start in your own establishment, you will not forget or drop any skill that you have acquired. So and as Prof said, so like Abuja and other parts of the country, they are also doing that training there too.
Thank
Hope
you,
able
sir.
to answer your question now.
Thank you, sir. Yes, you are, but the training for like in Ibadan now, is it for 6 months or 2 weeks? Because the one we came for at that time, it was a seminar. It was just 2 weeks. But the one that Professor Imaralu mentioned
Yeah,
now,
that
he
one,
said it one he mentioned now at Oka, Abuja, I think it's like for 6 months. That was what he told us. So, but the one that he's talking,
No,
that
it's
we're
not,
talking about now,
not 6 months.
sir?
It's not up to 6 months. It's not up to 6 months. What you attended, I think what you attended at Ibadan was just a conference. It was a conference. Yes. There is basic training, there is advanced training. But I don't think any of them is even up to 6 months, depending on the modules.
no, it's
But
not
maybe
up to 6 months.
let's talk about it's not up to 6 months.
It's not up to 6 months.
So
Thank you, sir. Thank you. God bless you.
Do we have any other question? Any question from the participants? I think we have exhausted the question from the participants, and I would like to call on the CEO. Mrs. Adibusola.
Thank you so much, everyone. Thank you, Prof. Imaralu, for the insightful presentation. Thank you for showing us, in fact, for teaching us about the the trends in gynecological surgery. You mentioned the drivers of change. You mentioned advances in MIS, which is really good. And you mentioned on robotic assisted procedures as well. I believe those are great innovations, even in advanced countries. For example, I'm in Ireland, and the use of the MIS, minimally invasive surgeries, and the robotics especially have increased the need for ambulatory centers to be opened across the country, that patients can just walk in, have the procedure done, and go back home in few minutes. Like, it has really reduced the hospital stay. And the challenge is mostly in maintenance. For example, if a facility should get a robot for procedures, you come to discover that either you use that robot or not, you have to pay huge amounts from the facility to maintain the robot. And because it has to be maintained, something worth thousands or millions, if you don't actually maintain it, it could get spoiled and a lot of things could go really wrong. And training and retraining is another challenge as well. As has been mentioned, there are facilities if you're in Nigeria. I'm not sure about other countries. I didn't hear other countries asking questions. Probably maybe they have other centers or alternatives, or they are trying to come up as well in relation to advances in minimally invasive surgeries and gynecological surgery generally. So I want to thank you, Prof. Imaralu, for honoring our invitation. Thank you for sharing relevant knowledge. We know that you've always been coming and you've been impacting us in various ways. And the session is recorded. With your permission, I believe we can publish that and share across our platforms. And if you don't mind, we will need the documentation as well from today's webinar so that we can share with the audience, with your permission, if it's okay, sir. So thank you so much for honoring our invitation. Thank you to the Education and Training Committee for facilitating this session. It was well organized. It was professional. Thank you so much for doing that. I believe we have another webinar coming up in the next 2 weeks. And that webinar is on enhancing human factors and civility in the operating room. And it's going to be anchored by Nigel Roberts. Right, Nigel is a PhD scholar and is the head theatre practitioner. That's the HOD of the department, one of the hospitals in the UK. That's Birmingham Hospital. So he's going to be speaking to us in a few weeks' time. And there is always a global webinar every 2 weeks that everyone can connect. I want to say a million thanks to everyone who connected from all over the world. Good morning, good evening, good afternoon, good evening, depending on your time zone. Thank you so much, everyone. We'll see you all in next session. And the webinar is going to be shared across the platform, the recording of the session. Thank you so much, everyone. Bye.
Thank you very much. Bye.
You're welcome.
Bye.
Bye, bye, bye.
Bye.
Bye, Ms. Olave.